Okay, so I'll be talking today about work we've been doing involving community engaged research for medical imaging. So first I'll give a little bit of background. So my focus and the focus of my group has been medical imaging and the intersection of AI and medical imaging. And we've been working in this field since about 2015. And so starting in 2015, we first entered the field. There were a bunch of groups that were starting to look at this hypothesis of can AI achieve expert level performance on medical image diagnostics tasks. And so 2015, 2016, we started to see papers come out with figures like this, where we were able to show that with sufficient training data and high quality labels, it was possible to train AI models to achieve performance on par with medical specialists for tasks like diagnosing diabetic retinopathy from fundus photos, which is the example you see here. Throughout the next several years, these findings were sort of replicated in many studies across many fields, subfields of medical imaging, to the point where, at some point in the 2015 to 2020 span, it became pretty clear that with the right labels, with the right model, you could train an algorithm to perform on par with specialists. And so, but this was all kind of done typically using large-scale databases of medical imaging data, kind of stored in a server somewhere. And so the new challenge, I think, for 2020, starting in 2020 around that area, but certainly continuing well beyond today, is how do we take those models that we've trained on these data and actually make them useful to patients and in a way that results in better patient outcomes? Because really that's the promise of applying this technology in this space. It's great to train these models, but if they're not actively out there in the world helping patients, it's just an interesting tech demo. So this is where our research has gone, and I think a lot of the research in the field is going now, is it's kind of more of a human AI interaction question of, okay, we have these tools that we can build now with AI, but how do we deploy those in a way that results in better patient outcomes? And that's where I think that community engaged research is the key to making progress here. It's in understanding what happens when this AI gets into the hands of the folks for whom it can be useful. And so I'll try to illustrate this with a bit of our experience in progressing through, and maybe like difficult lessons learned on my part and on my team's part in why this is so important. And so as many great stories around learning go, this one starts with failure. I mentioned screening for diabetic retinopathy. This was the first area in which we tried to sort of go beyond the paper to actually get this out through prospective trials and deployments. And from an early stage, when we were trying to do this prediction, when we were way back where we're just looking at images in a database, it was obvious immediately that image quality would be something we would have to handle, because if you look at fundus photos, they're actually somewhat difficult to capture. You're taking a picture of the back of the eye, so lighting conditions, anything blocking the photo from in the lens, cataracts, things like that, can get in the way. And so we started pretty early on with, okay, well, let's train, in addition to training an algorithm to diagnose the disease, let's also train an algorithm to measure the image quality and whether or not it's gradable, whether or not it's sufficient quality to be gradable was kind of the initial prediction we made, because we figured that would be the useful one, right? If it's gradable enough, then we can run it through the algorithm and get a good answer. So maybe a simplistic version of the world, but it's the one we started with. And when we rolled this out in trials, in prospective trials, we found in our earliest trials that 33% of the time, the images coming in from sort of a real world situation were considered by the algorithm to be ungradable. And that percentage is way too high for this to be useful in general. And so we sort of immediately knew we had a problem, and we were kind of in a situation where it's like, okay, well, we built this classifier, it doesn't work. What do we do next? And we tried a bunch of different things sort of to diagnose where the problem was, where it was breaking down. Really, the key insights came when we when we actually went out and engaged with a community of users who were actually making use of this technology, which in this case was the local nursing communities that we were working with in Thailand and in India, who were actually caring for the patients and monitoring the workflow and trying to get them through this workflow of diabetic retinopathy screening. And so this is a photo of some folks from our team in like a multi-day workshop with the nursing community that was where we were rolling this out. And once we were sort of working hand in hand with them in sort of a collaborative problem solving mode, it quickly became clear sort of where the problems were, where we might be able to adjust things to make them work better. Some of the examples of things that came out with this is it turned out that they had workflows where they had gotten around some of these challenges with image quality by just taking more photos. And then, for example, if they have two fundus photos from the same patient, one fundus photo where you can see half the image really well, and the other where you can see the other half of the fundus really well, they could sort of use that in their workflow to get a good result. But with the constraints we had put with the AI system, you needed one well-exposed fundus photo across the board. And so that was an example where we could sort of move them. They were comfortable moving away from relying on multiple photos towards instead focusing on the image quality of every individual photo, and even very simple things that they hadn't been doing before, like using a blanket to cover the camera and keep the light out, for example, to take a better photo, made a huge difference. And we were able to sort of quickly get that ungradable rate down to like 10% or so, which is the kind of the standard failure rate you'd expect to see in that kind of setting. So we learned a lot from that experience. And so when we moved on later towards other areas, dermatology being one example, we sort of took a more community engaged research first based approach. So in dermatology, the solution we were looking at was essentially an app where you can take photos of skin conditions and it'll guide you to information on the web that can help you make good decisions about how to handle this. So this is targeted directly to consumers, folks in their home who are experiencing symptoms of a skin condition and they want to find more information to help them figure out what to do. And so here we took an approach of, well, how do you engage? What's the community to engage here? And I think we've taken an approach of, well, there are many communities and we should engage with lots of different communities to ask different questions to different communities and get different perspectives. So I'll take you quickly through a few examples there. One of the first things we did was a very sort of diverse survey of many possible users with as diverse backgrounds as possible, just asking them, hey, if you had a tool like this where you could point your phone camera to your skin and get some useful information about your skin conditions, what are the good outcomes you would be looking for there? And so we got things like, for some folks, it's, I want physical relief from this condition that I'm experiencing. For others, it's, I want to know it's not dangerous, or I want it to go away. And so just sort of knowing what value we could potentially add to the users and the diversity of things folks would be looking for was quite helpful, even in the sort of earliest stages of figuring out what was the tool that we wanted to deploy. Another group we've worked with, another community we've worked with, is actually Google employees. So that group was particularly useful early on for us in just ironing out the kinks in the workflow of an app that you can use on your phone. What are the easy parts of using this? What are the difficult parts? How can we make that easier for you? So we learned a lot of the basics there of points of frictions that we as developers hadn't even thought about, but when we had users, Googlers testing it, we got to pretty quick answers there. But obviously Googlers are a very tech competent group and have all sorts of biases baked into that group. So we need to think about other communities to test this with, to learn from what their experience will be like. And so that's what led us to working with Stanford more recently. And this was a study that we did very recently. We're actually just looking into the analysis of the results right now, testing this Thermosys app end-to-end at the Stanford Skincare Days. Here, this is much more sort of a real world situation with users that are much more representative of folks we'd like to help with this tool in the long term. We had 30 participants here, 4 languages. Interestingly, we had many folks here for whom English is not their first language, which is a great opportunity for us to sort of measure with that community, whether this is helpful, where it's not helpful, and how we might improve it. And so this is a nice collaborative effort across multiple groups at Stanford and Google. And just to share some really early learnings, these are sort of, so early that the team was like, well, we're not sure we want to share these yet. So take them with a grain of salt. But I think that maybe the most interesting thing and the highest learning here was just that when we compare, so this is a plot at the top here showing in our testing I mentioned before with Google employees, just the overall satisfaction of, okay, how easy is this to use? How helpful is it? And you can see more red is more satisfied in general. So folks, the Googlers, we had sort of optimized this to be quite useful and to them. But then when we measured the same kind of question, it's not the exact same question, but a similar question with the skin day participants, you can see that the reaction is much more mixed. There's clearly a lot of headroom here for improvement. And that's kind of a, justifies that doing the study is like, yes, okay, there's going to be things we're going to learn here that will make this more useful, more helpful to these users. And so we're excited now to sort of dig into the data and figure out what are the aspects that could be more useful there. So in summary, a lot of the research we've been doing over the last several years in the space of medical imaging and AI was initially around proving AI works. But now we want to expand that to proving AI works for users, where users can be, many different communities. Community-based research, actually getting hands-on with the people who are using the AI is key to making progress in that space. And we have a lot to learn here. This is, I think at least a 5-year, if not a 10-year journey to figuring out how to make AI useful to patients and to doctors. And so I'm looking forward to working with you all to get there.
Thank you so much, Dale. Thank you for sharing the exciting community engaged research you are doing at Google with the diabetic retinopathy imaging and derm assist examples. I'm excited to have our next speaker up, who is Carol McCall. Carol is the Chief Health Analytics Officer at Closed Loop. She has over 30 years experience as a health actuary and population health executive. Carol has served as Chief Strategy and Product Officer for GNS Healthcare and as Chief Innovation Officer for Vanguard Health Systems. In prior roles at Humana, Carol led their Innovation Center's research, served as Chief Information Officer and as VP of Pharmacy Management. We're really looking forward to Carol's talk today. I'm going to pass it over to her.
Thank you very much. I've been really looking forward to the conversation this afternoon. It's going to be tough because I have a lot I really want to talk about and only a short amount of time. So I think you guys are giving me a 10-minute head start and then going to start chasing us all with questions. So I think it's going to be a lot of fun. So Closed Loop, we have healthcare's data science platform. We're one of the leaders in providing AI-based solutions. And we try to make it fast and easy for healthcare organizations to leverage data science to improve patient outcomes. We work with some of the country's leading healthcare organizations, and a big part of their strategy is trying to find ways to integrate data about the social determinants of health. And so there are two things that I hope to do today. One is to share how we think about integrating SDOH data into AI models, and then share a couple of examples of where we've done this and what people have seen. So to kind of kick this all off, I think it's important when people think about SDOH data is to recognize that there are many sources of data at different levels. And if you take a kind of a socio-ecological paradigm and approach, to public health, we can think of it at existing at different levels. At the individual and interpersonal levels, you can see that there are many sources of SDOH data, and they all come with different strengths and weaknesses. You can see that you can get it from medical claims, you can get it from medical records, you can also get it from patient surveys. There's also data from outside the medical system itself, and it could be from social service agencies or from even from commercial aggregators, companies like Nielsen. And you can see a little bit that, again, each of these comes with strengths and limitations. In particular, some of the limitations today have to do with how complete some of the data is. There's a lot of people that are using, for example, claims data from commercial insurance companies or Medicaid plans. And I think it's well understood that a lot of the racial data, for example, is incomplete. And even some of the constructs, when it comes to race and ethnicity, that those are fused into one construct in the Medicare data. There, as you look at some of the other sources, you can see that some of them are limited in terms of their collection. They may be difficult to link to other data, and some of them may actually come at a pretty substantial financial cost. At the institution and community levels, there are other kinds of data that are available. And you can see that there's over 100 different sources of publicly available data from non-medical agencies. And there is examples of that are from the American Community Survey. There are different indices like and aggregators like County Health Rankings. There's Area Deprivation Index, Social Vulnerability Index. There's a Child Opportunity Index. And there's a lot of data from governmental bodies and medical associations. You know, again, a lot of this data, it comes with its own kind of strengths and limits, and a lot of the limitations you can actually see here. But suffice it to say, there is a lot of different data that is available across these different sources. At Closed Loop, we make several of these sources available, and you can see them listed here. They're integrated into our platform. And you can see this feature, this thing we call a feature generator. What that allows us to do, there's a technology that we have that allows us to integrate multiple features, and you can see the number that might be generated kind of in one easy step. And you can see that these are the different publicly available assets that we make available, such as Area Deprivation Index, the Child Opportunity Index, Social Vulnerability, and the like. Some organizations also bring their own proprietary data that they've collected. They may be using a social risk assessment survey, and we can integrate that data as well. But the reality is that for a lot of organizations, this publicly available data, it's often their first foray into using any kind of data around social determinants of health. And so while we keep our eye on the prize with respect to whole person care, we try to figure out ways for people to quickly integrate, you know, readily available data so that they can begin using it and seeing what it actually has to say, you know, about some of their patients. Here's how some of them are using this. So there are examples of how HCOs are using this kind of data. And so you can see that with some of the in this table, these are examples of some of the data sources. And we've seen different organizations use it to map out different interventions. For example, some people have used it to identify people who might need housing referrals, or they might have risks related to indoor air quality. We've also seen people use it to make referrals to community-based organizations around when people might be living in a food desert. So there might be a mobile grocery store. They, again, might be using it around housing referrals or access to care issues around where they actually need to expand, you know, their networks. One way to do that is taking advantage of a capability to geolocate what's happening. So one of the things that you can do, if you know a person's address, it's possible to calculate features for things like how far do they live from their physician, or how far are they from their most frequently visited pharmacy. In this example, what you're seeing is this is a patient that lives in Berkeley, Texas. They travel 70 miles to see their cardiologist. And this is something that when you have certain kinds of data and you have the ability to geolocate things, it allows you to identify and begin to resolve barriers that individuals may be facing with respect to access to care or housing instability and things of that nature. I want to actually look at a couple of examples where our customers have used this. Before we dive into those, it's worth saying that none of the models that we work with our customers to build are pre-trained. So we don't sell models. What we have is we have a platform that builds models from the data that people bring. And so each model that we build is built from customer-specific data, and each one can be built or customized to include or exclude certain kinds of features. So for example, we had one customer that wanted to predict, you know, ED visits, and they wanted to use almost exclusively SDOH data. And it was a really interesting example. This one is an example of a customer that is predicting pediatric unplanned hospital admissions. So in this particular case, the predicted event are future unplanned hospital admissions in the next 6 months. the target population for this are children under the age of 18, that they have non-complex chronic disease, and they're in a Medicare population, or excuse me, Medicaid. What you're looking at here is the output from our model summarized across a population. And what you see listed down the side here, these are the different features that are predictive. And so this is a summary of, by the strength of that variable, which ones were the most predictive and to what extent. You can see the color coding here tells you what type of variable it is. Some of them were social determinants of health. That, in fact, in this was the top variable. So COI stands for Child Opportunity Index. And for people in this population, the social and economic score from the places where they live turned out to be the most predictive factor of an unplanned hospitalization within the next 6 months. Next was a care utilization statistic, and that was the average number of distinct prescriptions that were filled within the last 6 months. But as you go down, you can actually see that what is predictive for this population, what best explains the model, is really a combination of different characteristics that span SDOH factors, care utilization, demographic, as well as diagnostic history. In a different example, and this one is looking at adult ED high utilizers. In this case, this was built to predict ED visits within the next year. And so we're trying to look at 2 or more ED visits within that time period. And the target population in this case was an adult member in a Medicaid population. And here you can see that by far and away, the most predictive factor was one of care utilization. It was the average number of days it actually took somebody to fill a prescription. You could also see that there are other things. The next one was the distance to the most frequent pharmacy. And so that was, it could be the thing that is in fact deriving that first factor there. There's also distance to most frequent general practitioner. And so these two together were an access to care issue that were responsible for a large portion of these particular predicted events. In general, what I would say is that we're incredibly excited about the work that we're doing with our customers every day to actually, help their intervention programs and leverage this SDOH data. But having said that, we also recognize that there's a lot of work to do to build the evidence base for interventions that focus on the social determinants of health. Because the fact of the matter is that the rising tide of interest and investment in SDOH interventions, while it's necessary, while it's laudable, it has led to a tendency for some HCOs to implement programs without having evidence of effect. And this broad and sometimes blind application, it can be costly, but it can also breed some cynicism when they don't actually get a return on that particular investment. And so I think it's important that in addition to the enthusiasm, that we recognize the reality that there are significant gaps in evidence, and you can see some of them listed here, but that we do to build that evidence base and to fill in those gaps, that we take a very targeted approach. And what experts are recommending is that they're arguing against a kind of more is better approach, so that healthcare organizations don't feel as pressured into these broad applications, and instead are arguing for a very targeted approach to identify patients who truly need and would substantially benefit from interventions designed to address the social determinants of health. And to do that, they really outline 3 different things. They recommend that there be comprehensive screening for social needs, and that screening be at an individual person level. Despite all of this great data for SDOH that's publicly available, that has to get married with information about the person from the person. The other 2 things are to develop rigorous evidence of effects. A lot of HCOs, they don't evaluate their interventions, and yet creating the evidence we need means turning that on its head. It also means approaching it in a way that's agile and measures outcomes that are beyond just utilization. And last, it requires policies that incentivize this kind of targeted approach, so that HCOs feel like they can be targeted, but then also holding them accountable for examining the effects of those interventions. Because we believe that if in fact we do these things, leveraging this data and in this particular way can be a real game changer. And so it really means identifying the critical factors, shaping intervention design and improving efficacy of those interventions, enhancing the actionability. Social SDOH can help do that by identifying the factors that are driving risk and using them to assess algorithmic bias and monitoring the impact of intervention so we understand what works for whom. And with that, thank you.
Thank you so much, Carol, for sharing all the great work that your team is doing on social deterrence of health data and sharing those great specific examples of how to incorporate SDOH data into AI ML models. I'm now excited to introduce each of our panelists and have each of our panelists provide their reactions to the two case studies that we just heard. I'll go ahead and introduce our panels one at a time and have them give their reaction. Our first panelist is Dr. Justin Ko. Dr. Ko is a clinical professor at Stanford University School of Medicine, where he serves as Director-in-Chief of Medical Dermatology, as well as an Associate Chief Quality Officer and Physician Partner to the Chief Patient Experience Officer, as well as co-chair of the Clinical Advisory Council at Stanford. Thank you for sharing your reactions, Dr. Ko.
Oh, thanks so much, Rhea. It's such a pleasure to be on this panel with this topic. What an amazing group of individuals. Dale, I so appreciated hearing your presentation and your reflections and your honesty and vulnerability about the path that you and the Google team has taken. I'd love to maybe reflect on and share some of my reactions to that. First, just want to really say how resonant that was, the framing, Dale, that you showed about the path from AI working to AI working for patients. And as part of the group, I was fortunate to be part of the group that did some of that work early on, showing the potential of AI to classify skin lesions. That was one of the things that we recognized in doing that, which is getting AI to work was an achievable end. There was a way, a process, a technical way forward. But in many ways, that was the easy step. And I think that was this disconnect between a lot of the hype around the time where people were thinking and asking, you know, when is this going to revolutionize the field? And sort of our intrinsic kind of understanding that, hey, you know, we're only one step of the way in proving out this possibility here. And boy, there's so much more to it than that. It's then that I think we knew, I don't think we knew with the maturity and sophistication that I think we know now that really how challenging that second step is and will be. I think the introduction, when we introduce a living, breathing human being into any process, it gets more complex. But here we have one facing, you know, medical uncertainties, right? This is truly a sort of high impact situation. And maybe if I could just share three things that I appreciate about this collaboration and this work and this community engaged research that we're now a part of with your team, Dale, over at Google Health, and as well as Mike's team over in Santa Clara Family Health Plan. The first point that I appreciate about this is that we're approaching this from a place of curiosity and humility. And I don't think that's always a given, and I don't think that's always that's always true. But I think I love the end of your slide, which is that there is more to learn, and absolutely, technology is not an end in and of itself, right? It's not it doesn't equate to direct patient benefit. There's a gap that we in Durham and our research group we call pixels to practice. That gap between pixels to practice is really significant. And in sort of applying and understanding and doing the research in the real world setting, we reveal the complexities. We revealed, Dale, you showed examples of the ingenuity of systems and people and processes. And then we moved from the work of our AI scientists and engineers to the work of our qualitative researchers, right? Our design engineers, our biodesign folks, improvement, implementation science, human factors approach. It's a different kind of work, and it's a different kind of study. And approaching that with that stance of humility and curiosity is what I appreciate about that. The second is how we've been intentional about who we partner with, right? So sometimes there's this paradox in technology where the people who are best able to benefit are also the ones who find the technology least accessible for whatever structural reasons or logistical reasons. These are also the individuals who have greatest challenges in accessing our care, being in our clinics. They sometimes will have technological capability limitations. They also have cultural and language barriers, right? And we intentionally chose and went and sought a partner who would help us be able to understand and work with a patient and community to help us close that gap and that digital divide, rather than going for the easy populations of ones who are already in our orbit, right? Ones who we readily have access to in our clinic and you have access to in the employer base at Google. The approach here, I think, was also one that led to a lot of extra work, right? Let's not sugarcoat it. Honestly, translating things into 4 different languages is an extra step. It's an extra logistical barrier. It's a burden. But I think it's so not only worthwhile, but I think it's an obligation that we have in order to look at, if we want to look at real world application, we want to find those communities who really can benefit the most and who really, maybe if we weren't intentional about our approach, we would have the least amount of information into. And then the last point and the last reflection that I wanted to provide in terms of my appreciation about the work is the fact that we're looking across the continuum of interaction. And I guess what I mean by that is that we're not just looking at the user and the tool. We're actually thinking about what happens next, right? So we don't want to look at that interaction in isolation, because we know that there is a system of care that happens where patients will have a tool, but they're going to have what comes next? Am I satisfied with just the result, or do I want to interact with my care team or a clinician or something else or somebody else? And so I like that we are looking at that full stack, that full spectrum, and saying, okay, how does this now fit into this care interaction? And how do we understand meaningful measures, right? So we've moved, thank goodness, way beyond, is the classification correct, right? That's interesting, but that's not impactful. It's, what does the patient care about? What are they worried about? What are they wanting to understand more? What are those clinical impacts and outcomes that really matter to the patient and also to the clinician, right? So now we're introducing another individual into this interaction, and now it's almost like a 3-party interaction. We've got a user patient, got maybe a clinician, we've got a technology tool. How does that interaction happen? How do we get everybody to be able to be better with that? You showed that 2-step approach. Does the tool work? Does the tool work for the user or for the patient? I would add on, does the tool work with the user and with the system? And how do we understand that augmentation of capabilities? It's incredibly exciting work. I agree. It's 5 to 10 years of work if we could just get the message out there that everybody hold on, we're going to get it right. We're going to do it right. It's so exciting and so incredible to have partners like your group and our community partners to do this work and go along with that journey. But thank you for the opportunity to share some of my thoughts and reflections on that.
Thank you so much, Dr. Koch, for all those great insights. Really liked the quote, we are approaching this with curiosity and humility, and I think that's definitely something to take away. Next, I'll pass it over to Dr. Lee Sanders. Dr. Sanders is a general pediatrician and professor of pediatrics at Stanford, where he's the chief of division of general pediatrics with joint appointments in health policy, epidemiology, and the Hasso-Plattner Institute of Design. Thank you, Dr. Sanders, for sharing your reactions next.
Yeah, I just want to echo some of what Justin just shared and my enthusiasm, Dale, for the work that you're leading, and Carol, the work that you're leading. And from my perspectives as both a primary care provider, but also a clinician scientist working across disciplines. Also to echo Justin, I will try to summarize my reactions in 3 parts. That tends to work. And offer 3 frameworks or mental models that might be helpful to those of us here on the panel, but also in the audience. So the first framework or mental model that I think about when I hear what you shared is the socio-technical model of AI research. I've been very influenced by Fei Li here and Barbara Gross, who's my mentor and a leading NLP researcher at Harvard. And what they have impressed upon me is the great potential of these algorithms, not to replace humans, but to augment us, so that primary care providers can really go back to doing what we need to do. Same thing for subspecialty care providers. Justin is not only a panelist, I will reveal also one of my care providers, who is, and while we're doing this, I'm also acting as a patient. But what I really want to say is that to echo what Justin was sharing about humility, what we do in socio-technical research is humble inquiry with the people who can define the problems, where we need the augmented solutions to allow us to be more human with other individuals. And I'm gonna lead that with that large framing into the second framing, this overlapping, I think would be useful to us. And it's called community-based participatory research, which is, I'm thankful to the organizing committee for the title of this session. So community-based participatory research, for those who don't practice it or do it, actually is a pretty useful methodology for this work that is really employs deep listening to community members. I think, Dale, that's what I saw you beginning to do out there in Thailand, India, and even with the Googlers, and Carol, that I know that you do in your own work. But sometimes we skip some of those steps. And one of those steps is defining the problem. Sometimes we get so excited about a new solution that we forget the value of really listening to the community to define the problem that needs to be solved, right? And I think sometimes we need to step back and do that. I know we do that in our D school, design school classes. Just this week I was doing that. So I won't go through all the principles of that, but for those of you, you can Google, we have a Googler here, Google CBPR, learn about, really try to put into practice some of those deep principles. They come out of public health schools. And the final model I want to offer is a health equity model. I direct a literacy lab where we look at literacy as a lens in a lot of these issues. Turns out that 1 in 3 adults in the US and globally struggle with understanding some of these things. I think, Dale, you displayed that well in the contrast between the community sample and the Googler sample. But what we usually think about, when we usually intuit with the health equity model, is that it's all about access. But in fact, what drives health equities or health inequities is not just differential access. It's differential access for people at differential risks. I think Justin was touching on that. Dale and Carol touched on that as well. To something that's highly efficacious. So if we don't know what it is that we want to get to that's highly efficacious, we should probably stop right there. An example might be highly efficacious screening for diabetic retinopathy. Great. But Carol, I was looking as a pediatrician at the model of hospitalizations, unplanned hospitalizations. There are a lot of unplanned hospitalizations that are not preventable and that do not have an efficacious intervention. But if we zero in on a subgroup of those that are highly efficacious, and we are really cognizant of what the highest risk group is, I think we're more likely to be swimming in the same direction toward AI solutions that are quite valuable. I think that also applies to the work, Dale, that you presented. So there you have it. Socio-technical model, CBPR, and health equity frameworks, I think would be really useful for us to all be on the same page on as we continue to stumble forward in this work and share our successes and failures. So I hope that's useful to everybody. I'll stop there, but thank you.
Thanks so much, Lee. I think those 3 models are definitely very, very helpful for everyone to take away. Our next panelist is Dr. Drew Bedgood, a pediatrician and clinical informaticist with the California Department of Public Health. He completed his medical training at UT Health San Antonio, pediatrics residency at UCLA, and recently completed his clinical informatics fellowship at Stanford University. Thanks, Drew, for providing your reactions.
Hi, yes, and thanks for inviting me to the panel. And before I start, I have an obligatory statement from the California Department of Health that any statements I make in this panel are my own and do not necessarily represent the views or opinions of the California Department of Public Health or California Health and Human Services. But thank you again, and thank you, Carol and Dale, for providing these brilliant and very interesting presentations on how we can use AI in public health for our patients. So some of the things that I specifically think about as a worker with the California Department of Public Health is, first, how can we improve the data that we already have and the influx of data that we will be receiving in the near future with Assembly Bill 133 and the California Data Exchange Framework. One of the big issues that we see is, how do we marry these different sources of data that Carol had mentioned? It's very easy for us to understand, the standardization that happens with traditional medical data using like our USCDI data elements and ICD coding. However, now that we have such an interest in SEOH data as well, a lot of times those data elements are not standardized and do come in a lot of different formats and free text, and it's very hard to interpret and actually even use that data. So the work that Carol had mentioned, improving the data quality and completeness by using those variables and trying to fill those gaps for race, ethnicity, for example, is extremely valuable, because without that data and just the null values that we have, we can't really do much of an analysis. So it's great to see that there's a lot of work being done using these advanced models to generate that missing data and help us improve our registries. The second thing I think about is, how, once we have this data, how can we answer the questions being asked of us by our policy leaders, our patients, and even researchers? Dale, this kind of gets to your work as well, with, how do we define the problems that our patients are asking? We can provide a tool, we can provide the data, but if it's still not able to answer, their specific questions, are they sick? Are they, is this an emergency? Things like that. Then we're still kind of missing the point. And keeping our patients in mind as a key stakeholder, I think is very important in the path forward with AI research. And then lastly, I think, how can we improve the lives of all Californians? Keeping an outcomes focused approach is going to be critical. If we create models and, show off all of the technology advancements that we have, but it's not actually making a change, then, we're kind of spinning our wheels, and really focusing on those outcomes is important. And then lastly, thinking about the health equity and the hidden populations, especially in California for the state. We have to focus on both the entire state and regional differences in the data. And how do we do that? And using this data and using these models for that work will be exciting in the years to come. So thank you, guys.
Thank you so much, Drew. Our next panelist that is going to share a reaction is Mike Gonzalez. Mike is the Director of Community Engagement for the Santa Clara Family Health Plan, a local health plan in Santa Clara County, serving the health and well-being of over 300,000 Medi-Cal beneficiaries. Thank you, Mike, for sharing your reactions next.
Thank you, and for inviting me all here, and Carol and Dale. Yeah, my reactions, a lot's coming through my head. I had the pleasure of working directly with Dr. Stephen Lin, and also working with other folks with the Google team, the Stanford team. And I definitely think that when we want to improve, I think there's a question that was asked, Dale, from me around, what's good, what's good of a technology like this if it's not really improving health outcomes. And so in reality, as we want to ensure that we're doing well, we're able to improve patient health. Often the folks who we want to reach are the folks who are maybe have the least interaction with their PCP, or least interaction to knowing their health outcomes. And so how do we build technology, or how do we equip, for me it's about empowerment, how do we empower our communities to have more knowledge of their health? And so I think technology like this could play a big role like that. And one thing I liked about Stanford and Google's partnership, because we did work together, especially in thinking about community engaged research, and also community-based participatory research, is ensuring that we are listening to our residents, listening to the target audience were engaging, which is what I found which I love about this partnership. Often we create technologies without them in mind. And so I would tell you, there's over 400,000 Medi-Cal recipients in Santa Clara County alone. And of course, I know we have folks probably listening from across the state, other parts throughout the state. And so I think Medi-Cal recipients often are folks who are hardly reached. They are not engaged as much. They have to deal with a lot of difficulties, uncertainties in their life, especially during the pandemic. And often folks like us are creating things on their behalf, hoping to just take up our technology and use it. So I really did enjoy working with Google and Stanford, especially with the DermAssist program. But this also comes to mind what Carol was talking about around SUH data. Often public health organizations, including health plans, are really trying to leverage data like that to really determine how best to support and assist our strategies to improve health equity. I did agree with Dr. Sanders around the framework around health equity. When I think about the health equity framework, and I think about how this can connect to AI and healthcare, I'm thinking about how we can look at the goal of really of health equity is really dismantling or disrupting health disparities, often the root cause of that, which is poverty, right? And also a lot of it could be systemic and institutional racism and oppression. And so ensuring that this technology does not further perpetuate oppression, right? Like we're creating technology that they cannot engage. I think about oppression could be the digital divide, right? Folks not having internet access, folks not knowing how to use technology, not knowing how to, all those great, all the things that we acknowledge during the pandemic. How do we ensure that we're not doing that here, right? And so data like what Carol has been sharing, I take, public health folks like myself been doing SUH work for 15 years, and that's how long I've been in the work for. But I'm sure other folks that, I'm looking at Drew, other folks have been doing this longer than I have, perhaps. But we need to leverage data to guide our work. And so centering our patients, centering our communities in this process is very important. So I'm looking at both for the SUH piece. What came to mind, Carol, is how do we connect, how do we engage residents to collect that data? Residents do not want to feel that they're experimental, and that goes both for the AI point, but also for SUH point. So maybe, how do we collect data to further inform us, and how do we use our communities to do that? I also worry about the vulnerable populations, including the undocumented, right? How do we also inform ourselves through Medicare expansion in California? They will all be insured soon. They'll all be going to be folks we want to work with, right? So I have a lot of questions I still want to ask, but I think looking at both DermAssist and also Carol's work, it is inspiring, and it motivates me, and I hope it motivates those who are here today listening. There's a lot more to do, and I do want to end with this. I've been taking lots of notes because we can talk about this for a while, and I don't have a large platform here. I don't have enough time here to talk about them all, but I did want to talk about a few. I want to end with one thing, and I wrote a bunch of things down. One second, folks. Really looking at the opportunity to further this community engaged research perspective. What does that look like? How can we further build that frame for best practice? Not just what we learned here today, but how do we do that for all things related to health and healthcare, AI and other, SUH and other? How do we build that framework further? Because I think you mentioned it, Dr. Sanders, not everyone does that. How do we make that a standard across the board for everybody, no matter what we do? So I'll end with that. Thank you.
Thank you so much, Mike. Last but definitely not least, we have Dr. Rhea Paul as our final panelist. Dr. Paul is a faculty internist and geriatrician and Associate Chief Quality Officer of Population Health and Ambulatory Quality at Stanford Medicine. She was the CMO of an FQHC in Santa Clara County and currently serves as a board member of the Santa Clara Family Health Plan. Thank you, Rhea, for sharing your reactions next.
Yeah, thank you so much for inviting me to this esteemed panel. Can you guys hear me?
Yes.
Perfect. So again, excellent presentations. I do want to do a little bit of preface that I have been fortunate to be part of both communities, the Stanford academic community and also the greater community of Santa Clara County as the board member of Santa Clara Family Health Plan and the QI chair of Santa Clara Family Health Plan. And I do appreciate that all of you, including the greater community in this AI-directed research, because without that lens and the needs of the greater community, these AI-driven projects will be half-baked because there will be not much of societal impact from these projects. So thank you so much for including the greater community in these projects. So again, both Carol's and Dale's presentations were excellent. For both of them, they presented the different facets of AI. Carol's project was focusing more on the data part of it, and it was really informational for me, like how the data synthesis and can provide with some actionable insights. So this entire journey of data sharing, data analysis, and actionable insights are so helpful. And Carol, really appreciate your honesty and transparency that there are so much limitation in this S2H data. In wearing my hat as a population health leader, I really look at S2H data a lot, but really don't know what to do with it. So your presentation was really eye-opening for me. Like, we know that this is the right thing to do to better patient care and link patients to the appropriate resources available. But we know from either side that on the data side, there is some issues with the data, and also on the resources side, there are not optimal resources available. So in order to make the both of the sides meet, we have a lot to do, but this is the first steps that we are taking. And I think, like, without AI, I'm not sure how we can harness this enormous amount of information that is out there from various aspects, like from the government data, from the surveillance data, from the S2H data, the administrative data, and so forth. So there is a lot that will happen, I'm sure, in the years to come. And as far as Dale, that is another facet of AI. I always look at AI helping us in early diagnosis for particular diseases, and definitely AI linked retinal imaging, and also the skin cancer screening is the talk right now. And I know there has been a lot of discussions in the community too, because the community is really looking forward to resources like this. I know the waiting times to see an eye doctor in the community is pretty long. So how do, like, patients with diabetes in the community get their retinal screening? And if these community clinics or FQHCs had a retinal camera, they could churn out these pictures, you know, and AI could do the initial screening, and that would probably prevent like numerous eye complications from diabetes. So definitely this is the way to go for the future. But as you mentioned, there are still a lot of work to be done. Just looking at the two presentations, I do feel that that the involvement of the greater community will help in kind of providing better care for all, you know, in the long run. So thank you, both of you.
Thank you so much, Ria, and thanks to all our panelists for all of your really, really great insights. The last part of this session will be an open Q&A session. So I'd like to invite all our speakers and panelists to join in the Q&A session, and also all the attendees, please feel free to ask questions in the chat. For the first question, I'm going to have our response from Dale first. The question is, what does community engaged research mean to you, and why is it important for the advancement of healthcare AI? Thank you.
All right. I think we've talked about a lot of aspects of this today, but I can maybe summarize a bit, which I think for me, community engaged research means I think understanding what the help is you're trying to provide, and then talking to the folks you're trying to help to make sure your understanding is correct, that this is actually going to be helpful to folks. And then making sure that, you know, that, I guess going back to who are the folks you're going to help, making sure that the thing you build helps everyone, or helps the target, the group that you're looking to help, I guess. It's easy to sort of, especially for someone like myself who comes from a technology background, to imagine, okay, if I invent this cool technology, it will help everyone around the world, right? And I've seen many folks in my fields make this mistake in computer science and technology, make this mistake where they build a tool, imagining that it's going to be helpful, but they don't have a good understanding of how the world actually works and the details of how different people from different backgrounds in different situations interact with the world. And so concrete examples of this, actually, I can share this one, which is another somewhat entertaining one. When I first joined this field in 2015, I was new to healthcare, and I sort of stumbled into this opportunity around diabetic retinopathy screening as a computer scientist. And we had these images from a hospital in India where the leadership of the hospital was really excited to try to figure out if AI can be used to help screen for diabetic retinopathy. So I went and tried to educate myself on diabetic retinopathy. And then I went and spent, a couple of months with a team developing a model that could predict whether or not you had diabetic retinopathy. And it did really well, and I was super proud of myself. And we took this back to the hospital, and they very kindly explained to us that predicting whether or not someone has diabetic retinopathy is completely useless to them. There's no difference in how they treat the patients once they're screening with diabetics, and there's no difference in how they treat us. And the actual prediction they want us to make is between moderate and severe diabetic retinopathy. So, I swallowed my pride and went back to the table and started working. But I think, in particular, folks that come from technology are going to fall into this trap time and time again. And I think it's important for in healthcare for the folks listening here to be the people that bridge that gap from folks like me who don't understand healthcare deeply but do understand technology. Help us bridge the gap to solve the real problems that patients need us to solve. So that's kind of, I guess, maybe what the core importance for me of the community engaged research.
Thank you, Dale, and thank you for sharing that story as well. Carol?
Yeah, I think it's a great question. I'll come at it from a slightly different perspective, and I'll say right now, because we're a commercial enterprise, we're not an academic endeavor. We don't do research in the way that people traditionally think about it. But what I can say is that for us, the community that we engage, the healthcare organizations, they are doing research in the sense that they're all deeply trying to learn as fast as they possibly can what works for whom. And so a lot of our work is around population health, management, and outreach with value-based care organizations. And so there's really two different ways where I would say that I witness and participate in their deep engagement in learning. And one of them is around gathering new data, right? And so what we're trying to do, we're trying to go from burden to bonanza. Right now, all this data, there's so much, you talked about it, it's almost too big to know without AI. And part of our platform, we try to make it easy for people to say, look, what data you got, can't wait to regularize it for you and put it in and see what it has to tell you. And so we make it easy for people to do that. And so they're gathering new data and they go, I can't wait to see what it tells me. And examples of that are people that have gathered kind of special social risk assessments that they're using as part of their outreach. Another company said, you know what? We worked with them to identify, they were focused on heart failure, and in particular, using that as a part of their ACO reach to develop a health equity plan around reducing disparities in heart failure. And they had not been doing any tests around galactin-3. It's a biomarker that's been out there, really well researched, but is under leveraged by the clinical community. And they're like, we're going to start gathering this all the time, and we want to put it into our models because it's highly actionable. And so that was, gathering new data and using it in new ways and making it easy for people to learn from that. So that's one thing. The other thing I would say that we're doing, it's not just about prediction. The elephant in the room in healthcare around population health management anyway, is that we have to admit that we have a lot to learn about what works for whom. And this goes back, Lee, to something you said. It's not just access to care, it's access to an efficacious intervention. And so we can put up all these factors coming out of these models, but they need to be actionable and they need to drive action to something that matters. And the reality is that we don't always know what that is. And so we are creating capabilities that allow organizations to become true learning health systems and to actually learn from their own interventions in a very rigorous way to do rigorous program management and evaluation so that they can actually learn what works for whom and doing differential effects and all this kind of stuff so that they can learn in their populations. These things matter deeply and these are wasted. If it's not helping anybody, drop it, move on. You've got better ways to spend your money. And so trying to get people into that, our organizations into that mindset to be, curious, to really lean into learning new things is where we see, really big investments, paying off for us.
Thanks, Carol. We have a great question from the audience. I'm going to pass it over to Justin for the first response. The question is, as a physician with a technology background practicing in an integrated healthcare system, how can I best get involved in this community engaged research?
Oh man, that feels like a very personal question too, because that's kind of how I ended up doing some of this. So I'll, in the spirit of humility, transparency, honesty, I'll give you an example of maybe some of the things that we've done in the past, our approaches to both engagement and research. And maybe a good example of this, it still goes on in large scale in many places, is the concept of skin cancer screening, right? So, it's a skin cancer month and we say, hey, we're going to open up our clinics and screen lots and lots of people. That's great. Who ends up at those skin cancer screenings? Very often these are patients who, middle-aged to older, white, oftentimes male, and oftentimes patients who are already, in our health system or other systems. And so kind of the alternative approach is to actually, instead of saying, hey, this is what's needed, to go and say, hey, to ask what would be of value, what would be of interest. And when we do that, we find that this concept of skin health and diseases that are differentially expressed in patients of skin of color. Patients of skin of color, yes, skin cancer burden, but it's other diseases that actually have a higher degree of burden and opportunity for research. And so just shifting that mindset from paternalistic, this is what the community needs, to just what does the community need, and what are the partnerships, the tools, the collaborations? How can we approach this in a different way? And it really is, again, coming down to curiosity, humility. We don't know best, right? But together we can get to what we get to something that is better. And I think that's that approach. One, it's a mindset. Second is to find your community and find your people. There's so many folks doing amazing work here at Stanford and have been able to connect with some of them. But it's just find your people, find your group. There's no shortage of opportunities. And if you can't find exactly that group or opportunity, create your own. So many resources at Stanford, so many grants, so many programs, so many partnership opportunities that exist to get involved in the research.
Thanks so much, Justin. You're definitely such a great role model as somebody who's involved in so much community engaged research. Our next question I'm going to pass over to Lee for the first response. The question is, what are the major pitfalls to avoid and best practices to follow to successfully engage communities, especially vulnerable and marginalized ones, in healthcare AI research? Thanks, Lee.
Well, that's a big question. I will also take that humbly, and not the only person to have an answer for this. I think it's a communal and civic question with a communal and civic answer. I guess, some of this just comes from my bias, and where, I've been doing health equity, health disparities research now for 25 plus years. And all along it have been intersected with people from the technology community. And the biggest pitfall, and I think Dale alluded to this, again, thank you for your humility on this one, Dale, is thinking that you have the perfect solution or technology to every problem. So just, since I got some gray hair, so, like 20 years ago, there was a website for every problem. Then there became an API in Epic for every problem. And then, there was an app for every problem. And now there's an AI for every problem. So if I had a dollar for every fellow who came, or your junior faculty said, I want to come to Stanford to do now AI to solve every problem, oh my God, it will just blow up. So I think we need, just to echo Justin's call and Carol and Dale demonstrating this, this humility to problem define first and be really clear where AI or technology might be able to contribute but not solve. I think that's the biggest universal problem. Now, as to how to do that and how to elevate communal voice in this, I'll just share with you something I'm embarking on and would love for people to reach out to me and help me build. So I've also, because I've been doing this for a while, I've contacted lots of people who are, I will call fellow travelers in the world of health and design across the country, and have been working at the D School teaching for some time. There are a lot of people who are deeply interested in this problem. How do we elevate the voice of patients, and particularly people from vulnerable communities, as what we call co-designers or co-producers? And it's an easy question, but a hard answer. So I'll tell you things I've tried and what we're imagining. So I've actually brought patients into my classroom at the D School as well as into my lab. And it's really hard to do because when they're standing there and I'm in the room, they're going to say nice things about Dr. Sanders. What I need to do is to get out of the room and allow them to complain about Dr. Sanders, right? And have that safety of that space. And so we're experimenting with lots of different models. They're actually much more honest with my students when I'm not in the room than they are with me. And so what we're imagining, when I say we, these are colleagues of mine, not just in the Bay Area, UCSF and so forth, but in other communities like Fresno, Miami, and other places around the country I work with, is how do we kind of create these safe spaces, both in real space and as people get more used to Zoom spaces, where we can create a design studio for health equity that really elevates and pays. This is very important. Paul Farmer, we lost a great public health advocate in CBPR a couple of years ago. Read books about Paul Farmer. Pay people from the community to participate as co-producers. So it's always great to give me a little percent effort on your grants. Thank you guys. But what we really need to do is to pay folks from the community to do this. And to the last thing, so the first thing was, problem define. The second is pay people to participate. The third is really to demonstrate the respect by having a feedback loop, something we have classically done poorly in academics. We come in, we do a project, we publish it, we're done. And to feedback and really involve co-producers in every stage of the process, including presenting, getting harsh feedback, and so forth. And that's, I can share more with folks offline about what we're imagining for this design studio, but that's really the intention, is to involve partners. Mike, I'll be reaching out to you to see if Santa Clara Health Plan wants to be a partner in this, because we really want community-based partners, F2HCs that we work with and so forth, to be leading this and be paid to do this. I'll stop there. I hope that's helpful.
Thank you, Lee. Ria?
Yeah, I just wanted to piggyback on Lee's comments. I think the biggest pitfall is taking for granted the participation of the community. That should never be taken for granted. And that is the first step, in developing a good collaborative venture with the community, is talking to community stakeholders, being a part of the greater community for the last 20 years. You have to connect with the community stakeholders because their needs, their priorities, their understanding of the issue is very different from how we are looking at that problem. They are looking at short-term societal benefits, whereas we are looking probably more like advancement of knowledge, and as Lee alluded to, more for publications and so forth. And so we have to make sure that there is a connectivity between the two elements. And most of Santa Clara County is a melting pot of various cultures. So there are cultural differences. There is historical trauma from various cultures. So we have to be aware of all of those. And so the first step, definitely, as Lee mentioned, education, information, setting that trust building relationship, the feedback loop, all of that is the perfect setup for a good collaborative venture when we are including the community.
Thanks, Ria. Carol?
Yeah, I'd like to add on to even that. And I want to go back to something, Mike, that you mentioned, and Drew, something that you mentioned. So Drew, you're talking about, how can we answer the questions that we get asked, right? And if we can't, it all kind of misses the point. And then, Mike, you mentioned something about how can we inspire people? I'm paraphrasing, but we need more data to collect more data, but maybe different data. And I think that this is one of the biggest promises of AI and more broadly data science, is to make that easy to do. And what I mean is to actually issue a very humble and open and honest invitation to people in the community to say, this is about defining what are the questions that you want asked and answered, right? And to make it possible for them to literally gather that data and be a part of that design process. And so that they can tap into their curiosity around knowing the answer and tap into the desire to know and to be a part of a solution that really answers what they want to know. And I think that it's to me, it's a reframe. It's reframing what we see as research. It's reframing, how we see that it actually gets done and conducted. But it's kind of like this picture I saw one time, and it had one of those old IBM, AT computers, one of those XT things, and on one side, and it had an iPhone on the other, and said, we went from one to the other when we thought about computers as not for calculation, but for communication. And when we made that shift in our thinking, it made the iPhone possible. And I think the shift in thinking here is equally as powerful, but we have to rethink where and why and by whom research gets done. And I think AI opens that door, and data science.
Thank you, Carol. We have a question from the audience that's actually very on par with the comments that were just made. And Mike, I'm interested in your reactions to this question. The question is from a patient scientist member of the community who does research. And they say that co-design is tough in medical paternalistic culture. How can we listen first?
Thank you. This is the work I do every day with folks who are medical beneficiaries, folks who are uninsured, underinsured, folks who don't have time to care for their health and well-being. They're just trying to live. And the co-design model is very important. I think there's other practices or best practices that are out there around community engagement. One being a universal design. We design around the whole person, for example. Listening obviously is very difficult, and I think Dr. Sanders and also Carol and also Dr. Paul also brought this up around sort of the importance of sort of this community participatory research and engaging the target audience, but also what I think still that I don't think I heard it, and I want to just add to it then as well, is sort of this power dynamics of you're a doctor, and so they're gonna respect you, and like I think Dr. Sanders said as well, is they won't probably speak poorly of you in the room, but they probably have a lot of things to say that's important to improve their health. I think actually I would also want to recognize it's really cool that a person that I'm targeting in my head right now, which is someone who's hasn't spent time improving their health, made time to see a doctor. I think that's a great thing. Often, majority of people don't even have time to see their doctor, let alone talk about their health. But if you do get them to that point, how do we ensure that we're active listeners, and to the point we're building trust and rapport? I think we recognize power dynamics, right? So a doctor, me as an employee of a health plan, someone who's maybe facilitating a meeting, there's power dynamics we all have to recognize that can play in biases or the way that we lead a conversation. And I think there has to be level setting with people when we're on co-design, which we usually in the community we call as community agreements, right? Let's agree on certain things together. Let's agree on these spaces to make them safe. And so I think that's really important when we think about this co-design model or the universal design model, is how do you ensure that the people part of this work with you, right? Whether it be patients or just residents or partners even, how do we ensure that we have this agreement, this space of agreement, so that way we can have a productive sort of relationship in this project, where that might be.
Thank you, Mike. Drew?
Yes, I'd also like to take another kind of view on how we can engage communities in our AI research as well. And it really does come down to our biases in the data. It's been shown much more recently that we can build these models, but they're going to be inherently flawed by both the collection of the data and the just the nature of medicine so far today. And really understanding that and giving that back to the communities is essential in finding those flaws in the models and making sure that we aren't perpetuating any biases further on. I think recently there was a big study out of Mayo Clinic that engage their community to validate EKG algorithms and AI models. And, really, like I said, just kind of giving it back to the communities and saying, okay, we need your participation to make sure that we aren't, perpetuating these flaws, and really understanding that and kind of being humble in that approach and is really key, I think, too.
Yeah.
Thank you, Drew. The next question I'm gonna have Carol give the first response to, and it's what types of public data are most useful or overlooked in healthcare AI research and development?
That one's a little tough to answer. I think the thing that I see about the data right now and some of the limitations on it, there is no perfect data set. And for example, I love the county health rankings because I think that work has done a great job of really trying to understand the different domains within the social determinants and capture those over a long period of time. The problem with that is the first word, county. And when you start thinking about trying to situate somebody in a place that is far too high level of a resolution, you can go a couple, 3 blocks from where somebody lives and you can find yourself in a fundamentally different environment in terms of the built environment, things like that. The thing that I also find missing is information around policy, right? I think that when you cross, from one state to another, as we've been watching, the kind of the political, backwash in this country for the last several years, that the decisions that are made and the policy environment in which people live that affects the resources that are available and a whole host of things, that's another level where I have yet to see really, really strong data on that particular dynamic. I also think that I wish there were better data around kind of sociocultural dynamics or even language and languaging and kind of, for lack of a better term, kind of healthcare literacy, and yet even that just feels, I don't know, a little pedantic and all of that. So I don't see good data sources on that. I think race and ethnicity, it ends up being this combined construct, and it's far more nuanced than that. There's nothing in the data about gender identity or sexual orientation. So there's still a lot of hidden population. And the fact that still the data that we deal with is all about data on people that have experienced care at least a little bit, right? And so if you haven't seen the system in terms of the models that we build is still entirely blind about you and knows nothing about you. And that's, very unfortunate. There are other, if we get good at linking data across the social determinant sources, if we can link, care and environment and justice and education and housing, then I think you're really talking something. And I'll raise my hand all day long. I'd work for free to work on problems like that and link those data modalities to try to find opportunities. Because I think the interventions that we need, the actions that we need, So many of them are not clinical. And it's tough to kind of integrate and unite those forces. So anyway, hopefully that gives you some sense of data where I'd love to see some more work.
Yeah, thank you, Carol. I'm gonna pass the next question over to Drew to start us off. Carol already mentioned some of these, but could you comment on any other barriers or potential pitfalls in obtaining, using, and sharing public data sets for AI research and development?
Yeah, I think one of the big barriers that I see is also patient privacy and confidentiality with their data. This is a very difficult field to navigate, especially as a pediatrician, and adolescent confidentiality, that, you know, there are specific things that should be privy and should be private to a patient. And how do we separate and and segregate that data from the rest of the data that's being used to train models, without biasing it and without compromising their privacy in some way. So I think that is one of the potential barriers to using more and more data, especially if we are starting to integrate other sources where the data could be re-identified. That is another key struggle that I think we see and we fear, especially in public health, where we have multiple layers and aspects to data, where a lot of the research is on an epi level and population health level where it is de-identified, but we're also individually calling people and providing direct level care too. So being able to separate all of that out and still use it effectively is a big challenge that we're seeing and we're starting to think about as well.
Thank you, Drew. Gonna start this next. Oh, Priya, go ahead.
Just to add on to Drew, like I do feel that we have to overcome this data silos, even within the different arms of the government. That data residing with one arm of the government is not shareable with the other arm. So therein, we have so much issues in getting the data that Carol can use to synthesize these solutions, right? So I think we need some kind of government regulations, rules and regulations to help us go beyond that, to bring down those silos.
And if it's all right, I'd love to give another plug for the data exchange framework coming in California. Our state really is leading innovation in this, and a lot of exciting things to come in the next few years where we can integrate these silos of information effectively for everyone.
Thanks, Drew. Dale, we had a nice question about a possible solution for the data privacy issue being blockchain. Any thoughts on that?
So I guess first, I'm definitely not an expert in blockchain. My tech knowledge does not extend to too far in that direction. I think from what I do understand about that technology and the progress I've seen so far, I think it's in that stage of like, might be able to solve these problems, but it's not yet clear whether or not it will be, the one answer. The one I think I can speak maybe a little more to is around, so Google as a company has experienced this trade-off between, outside of healthcare in the past, between, asking folks to share their data with the company for some sort of value provided. And I think the approach that I've seen work well there has been one of just kind of honesty and transparency, where it's the onus is on the folks asking for the data to provide a very clear, transparent story around what is the value that they'll be able to return to you if you do decide to share your data with them. And I think that's a model that we can adopt here in healthcare, where we probably have to do a lot of hard work in advance with small data sets in really constrained environments to say, hey, here's evidence that if at scale folks are comfortable sharing this kind of data with us, here's the value, the very concrete value we can provide in return. And I think if you tell a good enough story there that in an honest and transparent way, then sometimes people are actually comfortable sharing the data if they know that they're going to get, you know, more value than the risk there that comes with sharing your own data.
Thanks, Dale. We only have a couple minutes left, so we'll move to the last question. Ria, I will call on you first for the last question, but I'd love to hear thoughts from everybody as well. The question is, what is your vision and hope by 2030 for the state of community-engaged research and public data in making healthcare AI more just, equitable, inclusive, and useful?
Oh, well, wearing my population health hat, as you know, that there is a wave across all organizations in managing their populations effectively and efficiently. And inclusivity and equitable care are the cornerstones for that, right? And we have to take our marginalized population along the way. Otherwise, the risk of uncontrolled hypertension, uncontrolled diabetes, it will be a huge burden for the greater community. One example is end-stage renal disease. Dialysis is not only a huge setback mentally, physically, but a financial setback for the entire community. And that is where I feel that AI can help develop this virtual programs to manage chronic conditions, early diagnosis of disease processes that Dale mentioned, and also identify high-risk patients, and also probably develop new modalities of treatment, right? This is my visual thinking. So in 2030, what I feel that developing a collaborative, trusting relationship with the greater community for AI-related research, which will help improve the care of all. You know, that is what I'm looking forward to. So looking at you, Dale and Carol, and
all right. I'm in.
Thank you, Ria. Any other closing thoughts from any of our panelists and speakers?
I was going to ask Carol about this. I was just going to add that there's great hope for learning health systems as well.
Yeah.
To leverage this AI data to the extent I think, Carol, you were alluding to about the county rankings, that when we're looking, when we trust the data that it's really showing us something about the population we're caring for, we're much more likely to reach out to colleagues, you know, across the county line, across the state, to find out what they're doing to produce better outcomes than we are. And so I'm really hopeful that this AI will allow those sort of social connections to flourish as well. I don't know, Carol, if you share that. But.
Yeah, I do. I think a lot of it is finding a way to easily, data is expensive to collect, you know, and so everybody finds himself in this kind of approach avoidance of, you know, should I do it? I don't know. It's really expensive. What are we going to get? And what I want to make, one of the things that I think there's a promise of is to learn as fast as possible whether or not the data is valuable, so that you can then, if it is, scale it up and out to be more useful. And so that we can get out of this love-hate relationship that we have with data and have it be one of just kind of unbridled enthusiasm, that we can go out and collect it and say, I can't wait to see what I learn next. Because it's not about the model and it's not about the data. It's about making it easy to learn. So this idea of a learning health system, I think we're at the beginning of something really wonderful, right? That we can in fact learn from data. We need to bring rigor, we need to bring humility, we need to bring, you know, curiosity, but this socio-technical infrastructures, it's not just technology. There has to be a, you know, it has to be a practice. Everything that we do needs to be available as data. We'll develop these disciplines, and I can't wait to see where we're at in 2030. Right. I think that the whole healthcare system is turning. We're at a tipping point, guys. We've got to solve this, or we're, you know, it's going to tip over. $4 trillion with a, you know, 1 trillion wasted every year that's a lot. but we can do this. And I love the work that I do with the people that I get a chance to do it with, and the innovations that people are really ready to begin pursuing are inspiring. They really are. So
thank you, Carol. we're at time. Thank you so much to all of the panelists and speakers for all your insights today. Thanks for the audience members for joining. And I think we can go ahead and end, and the Zoom will wrap up. Thank you.
Thanks, everybody.
Thank you all.